So, very good morning, everyone. People online have to confirm, at least in chat, if they can hear clearly. And today we are going to invest some time talking about Phase III Superiority trials. And I know from some of you that there has been some effort into sample size calculation also yesterday. So you're not completely new to Phase III Superiority trials. So what we'll do is that now today, many of us already know the theoretical aspect. So we will visit a lot about superiority trials, taking some examples. So these are my disclosures and conflict of interest. So some discussion has already happened. So all of us know that Phase III randomized trials are designed to pick up a better intervention than what you already have. But I think it is very important for all of us to remember that Phase III superiority trial doesn't always mean a positive trial, right? So negative trials are as important. So most important thing about a Phase III superiority trial is that it should answer the questions that are being asked, regardless of response. It may be positive or negative. So it should be structured in a way that it can test whether a given intervention is superior or not. And the presumption are many, but the best presumption that you have in randomized trial is that the confounding factors that can affect outcomes are distributed at random. And it is a law of nature that when you distribute things randomly, chances of having random bias are minimized. And at the end result, you can be reasonably sure that the difference that you are observing is the result of the only one difference that the population has, which is that of the intervention. Of course, there are a lot of things in between. For example, a Phase III superiority trial shows 4% difference. One can argue there is no difference. But for the test question you have designed, it is showing that difference. Phase III randomized trials are also very artificial because in one arm you will see 50% survival, in another 40%. So it still doesn't give you a very clear-cut answer, but it is still an answer. And at best, that is the most robust. And there can be two types. Why this term has been labeled as a superiority trial, because there are also non-inferiority trials, which I think Dr. Vikram is going to talk about that separately. But before I move to talking about superiority trials, I think it is very important for me to help you differentiate conceptually between the two. Phase III, the philosophy is one treatment is better than the other. And non-inferiority is generally looking into, so for example, today, I find that one drug does very good, like pembrolizumab for cervical cancer. 90% of the population cannot afford it, and there may be a biosimilar or an alternative. So non-inferiority trials are typically done to show that it is no different or not worse than what is otherwise the standard of care. So generally, non-intervention, non-inferiority trials are generally more on the ground, practical trials of interventions which can provide probably equivalent outcomes. They are not superior, but they are more, how you can possibly practice once you have a certain evidence where you cannot reach, right? And I will not go into the details, but there are clear statistical methods of defining what is superiority, what is non-inferiority, and what is inferiority. So, has this been covered yesterday for all of you? Okay. So, for example, this zero line, right, is the line of no effect, right, between interventions. So, if you see a hazard ratio, focus on A, that is less than 0. It can lie anywhere between 0.99 to 0.58. Till the boundaries of this benefit do not straddle the unity line, this intervention is considered to be superior. To what extent can be determined by the confidence intervals and the actual value. So you can see there is a dot here. So probably this will reach as hazard of 0.7. So you know that 30% can benefit, but then there is a confidence interval. But this confidence interval does not straddle unity. That means the quantum of benefit can vary, but this intervention is beneficial to varying degree, and there is no doubt about it because it doesn't touch unity ever. And then there can be other interventions. So you can see that B, C are crossing this zero line, but they are not exceeding the dark red line on the other side, right? So we cannot infer that treatment B and C are superior. Why? Because their 95% bounds are straddling the zero line. And then when we do trials, we always define benefit, but we also define detriment. So there is always a statistical boundary of detriment. So here this dark red line is the detriment line. So till any intervention doesn't touch that detriment line, it is not inferior. It becomes inferior only if it touches the damage boundary, right? So once you do statistical analysis, so anything that comes between this light red line and this dark red line is non-inferior, right? But if any intervention correctly goes beyond the dark red line, then it is inferior. So there is a statistical terminology, and that is how we determine intervention effect. So intervention A is clearly superior. But if you were to offer, for example, for patient intervention B or C, it may not yield as much benefit, but it is not inferior, right? So for example, for staging of someone, you have to do an MRI or CT scan, right? One may say MRI is superior, but I may say CT is non-inferior. Why? Because it is still getting to almost similar information. May not be as exact as MR, but still it has it. So I can say CT is non-inferior, but maybe X-ray is inferior, right? So this is how, but there will be statistical boundaries and certain tests applied before we come to such decisions. Now moving more on to, I will now just focus on superiority trials because non-inferiority will be taken. So I'm purely going to talk to you not statistically, but from the experience of designing various investigator-initiated, and actually it came to my mind that most of my trials are actually superiority trials that I have picked up. It's very carefully given me the right topic, which I did not realize otherwise. So when you design a superiority trial, what are you that you are trying to do? Basically, you are trying to prove that you have a possible intervention which is superior. So I think we all talk about PICO, but there are certain things as an investigator or potential investigator that we should run in our mind. First of all, what you're wanting to test, is it robust enough? For example, you have a drug. Let's take an example of, some expensive molecule, right? Nivolumab. And you have a phase 2 study where it shows a 4-week survival difference. I will not take it to phase 3. Pharma can benefit out of it, right? But for me as an investigator, it is a waste. I will not put an effort. Then there may be radiation technique, right? You have seen Janib is doing about some radiation technique. I have to be convinced that the quantum of benefit that it will produce will be of a certain level. Otherwise, why waste time in doing a clinical trial? Then another important thing is that we are proposing something. Is it feasible in the vast majority of patients? I'll come to all these questions one by one with examples. Then, are the estimates of efficacy well known? You may feel something is better, but do you have a percentage value that is allocated to it? Because when you're going to design a trial, statistician is going to ask you what is the benefit that you expect. You have those estimates. You may feel something is better, but you have actual numbers to it, right? And then, how you are designing your intervention 10 years down the lane, will it give you a clear answer for the question you are seeking? Because people do all kinds of confused trials because they want to accommodate multiple questions into one trial and then end up in a mess 10 years down the lane. So do you have a clean question? And then finally, you have questions, you have interventions, you have the right patient population to test that in. I may have, EGFR, drug that works. But if Indian population only 4% is going to be EGFR positive, then there is no sense. So having population and then whether potential confounders are counted, right, which can shift the result trials, and how do you choose then the endpoints, whether you are choosing one endpoint like primary or going to have 4 primary endpoints. So these are the things, this should serve as a checklist in designing trials. So let's talk about first thing. So first thing is there a robust intervention? So there are hundreds of drugs in the market, hundreds of techniques, right? Everyone, so tomorrow, as a person, I may just modify slightly my technique of doing procedure. Is it worth doing a randomized trial? No. So there are criteria which are set in that what is the quantum of benefit that should at least be there for something to be tested further. And typically for drug trials and for interventions, as an investigator, I can tell you, I always look into HR of around 0.7 to 0.74, because this is what will later on, depending on various things, may translate into anywhere between 9 to 13% or 8 to 13% difference. Anything that is less than that is artificial. Why? Because your clinical trials have this best population. If you show a difference of 4%, you can take it from me in writing that tomorrow at population level it will not make any difference. So we have to have an intervention which gives at least some sizable gain. Ideally, you would want that there's a 50% gain, but that is not realistic. We are not living in a magical drug, no drug, magical world, no drug, no intervention creates that kind of difference, right? Then we have to also see if there is signal of this efficacy in phase 2, right? Because you need background data. So this is an example that I put of all the breast, colorectal, lung trials which have been done in last 2 decades, and you can see that most of the investigators, their bioplot shows the HR and here the year of a recruitment. So in last 20 years, you can see this wisdom of investigators for most trial has actually fluctuated between 0.7 to 0.8. So 0.8 kind of trials are done more by industry, and investigators tend to take a lower margin. Also for sample size and practical requirements of not to swell up population. And you can see using this strategy, actually, these are the results these investigators have obtained, that the actual HR has been either in that range or even better than that. So this is a good example of various interventions in superiority trials that have been designed worldwide. So very important question. There are all kind of trials that are done worldwide, and later on we criticize this was not a good trial. So is the test treatment tolerable or feasible? So these are two classical examples. One of a complete, I would say, if I'm allowed to use that word, a bit of a disaster. And second is more real life. The first is critic study, which is designed in stomach cancer. So there were 2 trials worldwide. One was a trial in which adjuvant chemoradiation was good, and then there was another trial where pen-off chemo was good. So there was no consensus what to do in the world. So what the investigators did was compare these 2 approaches. But what different they did was they put new adjuvant chemotherapy, surgery, and then subsequent chemo and then chemorads. What they did not realize is that chemorads that was previously given was without this new adjuvant component. And when this trial completed, 50% of the patients could not receive chemorads. So if your test intervention, 50% of the patients cannot achieve, it is a useless trial because you have not been able to offer a test. And then ending up saying that this intervention doesn't work, I would have said good homework was needed for this approach of phase 2. Of feasibility before taking it to a randomized trial. Then there is another trial which we again of post-surgery chemoradiation and chemo. Here only 71 to 79% of the patients completed the test treatment. So this trial showed a clear benefit of 10%. But then if there was some more homework into patient selection, this benefit could have been 12%, 14%, or could have helped people select patients which tolerate this treatment. And I know from clinical practice that now in today's day, all stage 3 patients which this trial addresses, 3/4 of the patients only receive this treatment. Others are incapable of. So what to do of such patients, we don't know. I also give one example from our phase 3 randomized trial Parser. So here 96% compliance was there to test intervention. So designing trials assuring that at least 90% should receive that treatment is very important. Then coming to baseline estimates. So many times you have a new technique, right? But you don't know how much it works, right? I'm asking you to have correct estimates for sample size calculation. So there were 2 trials in world literature a decade ago that were designed. So there is this new radiation technique which is called as IMRT. People know that possibly it may have less late effects, but no one knows how much. So there are 2 trials that get designed internationally. one by the NRG Group US and second by our hospital. Both want to test if this intervention leads to less toxicity. But how much less? Neither we knew nor the NRG group. So both the trial groups, because they happen in parallel designs without any discussion. So NRG US uses effect size, and effect size is used when you don't have real estimates. You can say mild, moderate, and severe, right? Or mild, moderate, or a lot of effect. So they chose an effect size model and decided that this intervention has probably medium effect of 0.4, and this is where they landed. So they had no estimates. They thought that it will be 0.4. And when the final trial that happened, the actual observed size, effect size was 0.27. And to even demonstrate this effect size, the power dropped, which means that they end up with showing p-value of 0.05, but it has absolutely no meaning. Why? Because that intervention is not producing the effect. The trial actually, despite having 0.05, ended up being negative because they could not demonstrate that effect size. So good preparation is very important. So what we did in our study, we also did not have estimates. We looked into literature and presumed that there will be, say, 30% difference. We started trial with 18 and 5%, and then built in an interim analysis to get some estimates of what is the actual difference. And we were also all over the place. The actual what we observed was 24 versus 11. But we used this opportunity. So this is what I'm trying to say. Investigators start with certain knowledge that may or may not be correct. We ended up with a totally different estimate in reality. So we gave ourselves a pre-built opportunity for interim analysis. So we use these observations, use the trial alpha to remodel the sample size based on these new estimates. And then we adjusted the sample size based on this information and ended up with a positive trial. So this shows two important things. One, you must have baseline estimates properly, and if you don't have, give yourself opportunity in trial design to look into the estimates that evolve in the study. You can build in a planned interim analysis, a planned data look, where you can spend some of the alpha to look into these estimates and adjust the trial. We'll come more into adaptive designs a bit later. The third thing by designing intervention is that interventions have to be balanced. There can be only one deviation, which will be your test deviation. So this is a classical example of a positive phase 3 superiority trial, which did not change the world practice. Again, very important positive trial, JCO publication, but not in any guidelines. Right? This is a classical trial of a positive trial to learn from things not to do. Why? Because here you see they have locally advanced gynecological cancer here, and they want to test if adjuvant chemo is better. So normally patients will get chemoradiotherapy. So they designed this trial, 2-arm randomized trial, and in one arm patients get adjuvant chemo and in another no. Excellent, right? Perfect. But where they messed up is when they were giving concurrent chemo, one arm receives cisplatin and the other gem plus cisplatin. They have shown the kind of difference which no trial in the last 20 years has shown, clear-cut positive. But it never became standard of care because investigators could never determine whether that benefit came out of introducing gemcitabine along with cisplatin or because of adjuvant chemo. So 10 years were lost. And then there was another trial that was designed to answer this question, whether the benefit came from concurrent part or adjuvant part. And again, this is again a superiority trial out back. Very clean. You can see same chemoradiation. They omitted the variation of gem and just tested adjuvant chemo. And again, multi-centric trial, 900 patients, 10 years wasted. Again, a negative trial. Why? Because the patient population that they chose, they included all comers. They did not enrich their population to see intervention effect. So sequentially, by showing these trials, I am giving you examples of phase 3 randomized trials that turn positive but don't create an impact, and sometimes they answer the question but do not future-proof their trial by selecting the right population. So these are the building blocks: patient selection, using the right intervention, right HR, feasibility of approach, and these are classical examples of investigations going wrong. 10 years wasted, still no answer, right? So all of us started in year 2000, at 2020 we are same, chemoradiation, right? Multiple trials done, all by victims. So patient enrichment is very important. So for example, you have chosen an HR of 0.72. If I apply to all comers, chances that I'll get that kind of hazard ratio are less. So select your patients well, understand where the intervention is going to have benefit. So I've shown you how to back negative trial. So they included all kind of patients with cervical cancer. A mild enrichment was attempted by taking 1P1 and lymph node, but otherwise they included all other patients, right? So you would not possibly see that kind of typical, you call them not this one, but curves which separate early on and then just after some years just combine, right? So how do you enrich your trial? So this is one example of this is one example. Someone is not on mute. Someone in the audience is not on mute. So this is another example where you can use clinical criteria to enrich the trial, or alternatively now is the possibility, to also enrich using biomarkers, because a lot of targeted agents are coming. So you can select a population which is EGFR positive, PD-L1 positive. So these are the strategies. I will not go into detail, but these are examples of COBA trial design where only HER2 positive were included, and then you will end up with a positive trial. So choosing the right population is important. And similarly, you can have stratification according to biomarker. So these 5 or 6 main things that I've told you are the building blocks when you design superiority trial. Another important thing is you should adjust for potential confounders. So for example, I was designing a trial to look into late adverse events after pelvic radiation in a patient cohort that has undergone surgery. I can just run the trial with 2 techniques, right? You have advanced radiation technique and not so advanced radiation technique. But come on, this is a surgical trial. I will be so stupid if I assume that surgeon will not cause any toxicity, or the medical oncology drugs that are being given, they will not build. So I pre-built 2 stratifications. One, type of hysterectomy. If a surgeon goes more excessive, there are going to be a lot of scar tissue. And second, for chemotherapy, right? All medical oncology talks of 30-day, 90-day mortality, presuming that drugs will not have any effect. I think that is very naive. So I already, put these 2 stratifications in place to see that these could potentially confound. So having pre-planned post-hoc subgroup analysis is only hypothesis generating. It will not lead to any value. So if you think that there can be any confounders in your investigation, for example, if you're testing pembro, stratifying according to PD-L1, if you have a HER2 investigation, so this has to be built on in the trial. So these were the building blocks, and I think before, in interest of time, I should finish type of superiority designs and then take discussion if any. So superiority designs actually can also be of a lot of type, because till now what I've shown you is 2 arms, you look into the intervention. But a lot of adaptive designs are coming into picture, and also multi-stage, multi-arm and integrated designs, and I will speak a bit about them. So adaptive study design, what it does is, as its name is, it allows you to adapt, right? You can use some information that is evolving through the trial to say if an intervention is possibly efficacious or probably futile early on, and mostly it's done for futility. So if there is an expensive drug, and if you don't want to spend energy on 700 patients, you can build it statistically to look for futility boundaries, and we'll come to an example. So what an adaptive style does is, so you start here, but early on, say at 1/3 approval or even before half of the approval, you see for signal of futility or efficacy by defining your statistical boundaries, and it helps you to drop the trial early on if you don't see any benefit. However, if it looks efficacious, you go on to complete recruitment. But real life often is in between, where you don't know. So it also gives you an opportunity to expand your sample size to look into those benefits. I'll give you one study. We are doing this phase 3 randomized trial of a repurposed drug in cervical cancer, which is called as Inferiority. It's not a classical adaptive, but I'll show you how adaptations for futility have been done. So here, when we index calculated the sample size, we estimated an HR of 0.55, right? And test group HR of 0.64. And the study was designed to have 300 patients, 1:1 ratio. And you can see how while doing statistical design, we have boundaries defined for futility and efficacy. And we understood that study is going to have 154 events, but decided that when 28 events happen, you have a look. And if the boundaries of futility are crossed, study stop. Why? Because it's an expensive drug, which we outsource from abroad. It costs us a bomb every patient. Second thing is it's a repurposed drug. We are not clear whether it's going to benefit or not. And drug is not available in India. So I cannot spend my time, energy, and financial resources to complete the trial. I must have some signal before. So this is the classical adaptation, that can be there. But there are a lot of things happen while designing the trial. So design trial in 2016, and this is not an adaptive design, but what happened to us was staging changed in between, right? You are relying on certain staging to select patients, and in 2018, people announces that your staging system has changed. I have to report that trial 8 years later. How do I adjust for that? All my baseline estimates don't provide. So what we did was we reclassified our clinical practice patients. Then we reallocated, not the trial patients. We tried to understand, again, through a formal 700-800 patient analysis, that what the new staging system would mean to our estimates of efficacy for the standard arm. Because your standard arm changes when staging changes. Because what was previously 3B no more remains 3B. So what we did was, we fed into new estimates and recalculated the futility and efficacy boundaries. So this led to change in sample size from 300 to 348. So these are the adaptations that you can do real time. And then when you move ahead, of course, I'm going to again have a futility analysis. Previously, it was planned at 28 events, now at 32 events. So these are the kind of trial adaptations you can do on the way. One, for a classical statistical adaptive design, but then there are going to be bumps. For example, a new drug comes in market and standard of care changes. I will have to adjust, right? So this is how we do adjustments on the way, because a typical trial runs for a decade. So another trial design is an integrated design, and this I have done for one of our studies in hepatocellular cancer. So we've been talking of single-arm phase 3 randomized trial, right? So what do you do before phase 3 randomized? You do a phase 2 to get efficacy, right? But if you have to be smart and save time, you can also do integrated designs. Integrated designs means that you start up with a phase 2 randomized, let that give you some estimates of initial efficacy, and with the same study, build in a PFS analysis at early time point and move into a phase 3. So here is the classical example. If you do a phase 2 followed by phase 3, for example, for a certain estimate, you need 700 patients. For an integrated design, you will need 100 less. And 100 less for a single institution trial can mean additional 4 years. For multi-institution, 1 year. So it helps save time and resources. We can't go too much into detail, but I refer you to onlineclinicaltrials.gov, where we have this design. And this manuscript is also published, so you can look into how integrated phase 2, phase 3 design can happen. So the idea is to have PFS estimates at the analysis of phase 2 randomized part. If you see a signal in PFS, then you move to OS study.
Then this one question, can we incorporate the adaptive trial design with an integrated phase 2, phase 3?
So, we actually ended up adapting our integrated phase 2, phase 3 also, but we did not build in futility boundaries there. We have to adapt with alpha. So it is, at least to the best of my knowledge, I did not find, a lot of combinations, but adaptations on trials can happen regardless of the trial design, because in real life, trials are not artificial. They flow through 10 years. A lot of things change in 10 years. So one is the adaptation. So you're asking, can you combine adaptive design? So in the design here, actually integrated, futility is in a way captured in the phase 2 analysis. If I don't see a signal, I don't move forward. So it is in a way not classically, but it is also an adaptive design.
Yes, and but for example, if the sample size for the phase 2 part itself is large, and
it's never large. It's always set at alpha of 0.2. It is designed in a way that phase 2 part is short. Phase 2 has to be short, otherwise you lose the value.
This finally showed, but this isn't. I'm also doing a study with an integrated phase to phase 3. So the sample size I calculated as using the NCI online.
Yes.
For the phase 2 part, I took earlier EFS as my primary endpoint, and I relaxed my alpha and beta, alpha 0.2 and beta of 80%, power of 80%.
So what sample size you
I
have?
took 400 for the phase 2 part.
That's too large.
Yes, and 16 months of actual time. It's a multi-centric trial. So, and I just need additional some like 250 patients to complete my phase 3. So I was wondering, rather than like after 400 patients, can I build in an interim futility analysis for the phase 2
You
part?
should go for an adaptive design. That will help you better. Because adaptive design, you can choose 1/3 of the events or a certain number. Like if you have 600 patients, you can, for example, your patient population is going to have out of 600 patients, 300 events. You can choose at 80 events or early on the analysis. Maybe you can actually meet Sadhana later on because she has experience in designing both of them, so she can come with some advice or I can talk later. So I think before we end, it's very important that I talk about multi-arm, multi-stage design. It is not a classical phase 3 randomized trial, but it is a phase 2 selection design, also to select superiority. So this MAMS is, very popular within the UK group, and there are a couple of trials like STAMPEDE, also partially ISPI, which go with this design. So here the presumption is that normally how do we do trials? I have 3 drugs. I will put one comparator arm versus another. Then I will have 4 different trials. That is how you are seeing what I'm showing. So I think MAMS design is one of the most efficient selection design. So what it does inherently is it allows you to compare 4 or 5 different interventions in a certain way. I will come to it. By one, swelling up the control arm. So you always have double the recruitment in control arm. So for example, your traditional design would have 1:1 recruitment or 1:2 in favor of intervention. In MAMS design, because you're going to have multiple comparator arms, so your control arm can have almost double the number of patients, and then you can position up to 5 to 6 arms to compare with the test arm. Another beauty of MAMS design is that you really don't need to have estimates of efficacy of the test arm, because we've been saying that you don't have estimates of efficacy. What do you do? So what is beautiful in MAMS design, and I will come to it in a moment, is that it does statistical analysis based on the expected event rate of the control arm. So for example, if I have a standard intervention, you have a Kaplan-Meier, and you know that at 2 years, these many may be the number of events, at 3 years, these many, and 4th year, these many. And if I have another 5 interventions for which I don't know how their events will happen, so here the analysis trigger point will be the event rate of the control arm. So you can see I have done some calculations for another trial that we are designing. So you have multiple arms and the trial moves towards stages. And on the extreme right hand corner, I have put trigger events of control. All I need to define is the target HR that I want. And I have made up my mind that I will do most of the trials between 0.7 and 0.75. So I put a target HR here. And in the early stages of a MAMS design, when you are having different interventions, you keep the alpha very low. You can actually, the first stage, you will keep it as 0.50 because you have to allow drugs to move further, because events are not going to happen in first year, right? You have to have it going on, because the trigger one is, for example, 12 months. All events may not have happened, so you don't want to stop, assessing those drugs. So in first stage, you can have a very loose alpha, and as trial progresses to year 3, you can make the alpha going down to 0.2, 0.10, 0.5. So that finally that you get in selection is the most robust form. And classical examples of these MAMS design are STAMPEDE, for example, prostate cancer. So here we had control arm of hormone therapy, but there are at least 5 other arms which are testing different interventions which have been introduced. And this slide is very it's not zoomed in, but what I can show you is this demonstrates how the trial, a typical MAMS will flow. So you start recruiting, you have a control arm, and then you have multiple arms, which may or may not be starting at the same time point because they are different interventions, right? So first trigger will happen at whatever event rate, 12-month event rate of the control arm. Then you statistically adjust. If it's going outside bounds, you reject that arm. Then you proceed further, right? You have a trigger at which second statistical analysis will happen. You have again futility bounds. If these further arms remain between those bounds, they continue to recruit. If not, you throw it out. So by doing this, you can simultaneously test multiple agents and take the most robust agent further to go into a phase 3. So I don't have to sequentially waste time in doing phase 3 randomized trials for multiple potential interventions. It is time and resource smart. And now for most of the gynecological cancers, we are working into designing something like this, that we will have multiple drug interventions and we will move, because we have failed in the last 20 years, Outback, Gonzalez trial, other trials. I have given you multiple examples. So this is how we will move. So to summarize, phase 3 trials, I have spoken to you concepts and considerations that you need for trial design, given you examples, and final sample size that we often have is a balance between reality and expectations. And despite all the limitations I've discussed in last, 30, 45 minutes, they still remain the gold standard, because even now a lot has been said about adaptive designs, but there are only 5 to 6 good trials with adaptive designs which have come to fruition till now in the last 10 or 11 years. So future will tell us how things will move forward. So thank you very much.